on the IHOPE, which is the Indian Health Outcomes Public Health and Economics Research Center. And we have Dr. R.D. Ravindran as our honorable chair for this session. And we have a list of speakers on different topics. Apart from myself giving a brief introduction about IHOPE, I'm not sure if Dr. Namrata, she would be busy, but the role of AIS in guidelines and advocacy is what she would be talking on. And then Dr. Anthony Vipindas, my colleague at LV Prasad Institute, will be talking on big data in ophthalmology, including EMR. We have a special guest, Dr. Abha Mendirata. She'll be talking on introduction to HT or health technology assessment. She's a pediatrician by training, but she does much more than that. She is part of the Center for Global Development. She is the non-resident fellow in India, and also she did her MPH from Harvard, and also has been a consultant to the World Bank and other important agencies, including working with NICE. Then we also have our very famous secretary of VRSI, Dr. Manisha Agarwal, who will be talking on the efforts of VRSI in diabetic retinopathy, how we are involving the Diabetes Society, the RSSDI. And last but not the least, we have the specialists from ophthalmology in health economics. Will be Dr. Sunny Sengupta will be talking on basics of health economics and health insurance. But I would be starting off with just an introductory uh, presentation on IHOPE, what is IHOPE and what all activities we do. IHOPE is a collaboration uh, between LB Prasad Institute, IIM Ahmedabad, and IIPH Hyderabad, funded by the DBT Welcome India Alliance, which started in April 2020. It was formed with the objectives to develop a knowledge center which will create new knowledge and also disseminate knowledge in clinical and public health research, and attract and train talent in various forms. One is through the long term fellowship program that we have, and also through online learning platforms, which we have more than 900 people enrolled now in developing them as clinical uh, researchers, and also try to influence health policy in India based on new knowledge. So that is research to policy. And the IHOPE Center provides end-to-end support for any study, right from retrospective to prospective, protocol writing, study hypothesis, and all approvals to the data analytics, and also disseminating the information, also working along with the policy makers. Um, in terms of the projects, broadly, we are aligned with the overall objectives that the center has been developed for. I'll be listing some of the projects, but apart from the projects, the publications, we also have the IHOPE Journal of Ophthalmology, which is a unique journal focused only on public health, health economics, and guidelines publications. And then, in terms of the capacity building aspect of IHOPE, we have the CRTP program, which I mentioned, which is the long term fellowship program, clinical research training program. We have the online training module. We also have various webinars, monthly webinars, and also the IHOPE conference. In terms of research to policy, we work closely with the NICE of UK, NICE International of UK, and NHA, which runs the Ayushman Bharat program in India. Uh, just to give you an overview of the types of projects which we are handling, uh, some of them are listed here. The biologics and biosimilars competitive dynamics, based on the US Senate passing a law in biosimilars way back in 2010, I think, during President Obama's time. What happened to the dynamics of the biologics industry in India? And we all know biologics India is a leader actually, but that had a big influence on how the Indian market prepared for the US, or the Indian pharma industry prepared for the US market. And also technology diffusion. We have new technologies coming up. One of them is listed here as OCTA, but then we also have looked at other new technologies in ophthalmology, including LASIK and other refractive surgeries, and found out what were the various influencers which affect the overall uptake of these new technologies in terms of patient care. We also have looked at the gender differences in accessing surgical care. What are the differences between male and female in what age group? Just to highlight one point in here is that while most of the care we found males were taking more than females in terms of hospital footfalls or surgeries, but specifically in terms of refractive surgery in the age group of 20 to 30, it was females who were getting more surgeries done. Not just that, they were spending more also per surgery compared to males, and that probably is related to the marriageable age group which we have hypothesized. And also, other than that, we have been working on guidelines along with NHA, AIOS, VRSI, and Glaucoma Society. Also, we have formed a secretariat of IHOPE, which the members and the speakers who are here are part of that. The IHOPE journal is issued or published once in 4 months, so three issues a year. First edition was in January 2022, and we just released the fifth edition. And as I mentioned, it is not a routine clinical journal. We have been working with NICE on learning how the NICE international or NICE basically guides NHS with different guidelines, treatment guidelines. And so far, we have had six knowledge transfer sessions. We're working on the next packages with them. And we have included numerous organizations in these workshops along with NICE, so that most people or most organizations can benefit from these knowledge transfer workshops in India. As I mentioned about the iHope Learning Hub, uh, we have the Learning LMS platform where we have these clinical research, basic and intermediate courses, and also AI, artificial intelligence in health, and diabetic retinopathy grading. Various countries are, or students from various countries have enrolled in this, and it has picked up good pace. At this point of time, it's a self-paced course. Usually within 3 months is what most of the candidates are completing, and at least for the clinical research module, once they complete the basic course, they are eligible to go on to the intermediate course. I know Dr. Sen Gupta here runs a very popular course on clinical research, but overall these modules which we have multiple speakers from different universities, including the London School of Hygiene and also from the Wills Eye Hospital. We have also had two annual conferences. The third one is for this year, September 29th and 30th. Again, we divided into four verticals: public health, big data, health economics, and policy. And we have both Indian and foreign speakers in these. This year, we are going to include speakers related to Africa too. In terms of webinars, we have monthly webinars for our different aspects of health guidelines or public health and health economics. And one important area which we are looking at uniquely is patient engagement or public awareness. And they, apart from being involved in the patient engagement webinars, which are different from the webinars for the experts, they are also, patients are also, or lay persons are part of the guideline committees and also a member of the secretariat. And recently, Dr. Anthony Vipindas actually um, developed this new iHope community website where we will have, it's kind of a LinkedIn for us, where people who are uh, getting in touch with so many different touch points like the LMS, journal, and collaboration of projects can be part of this community, and they can actually post and chat like a LinkedIn community. The NHA Ayushman Bharat team has also had multiple interactions with us. We are looking at the health packages and intervention pricing, provide feedback, and also they have asked I hope to participate in the with us as a group, and also looking at updates to those packages right now. At the end, I would like to play a video. Actually, it's a long video. Develop. Oh, there's an audio and this it doesn't come here. So uh, I'll be. So yeah. So this is Hugh McGuire, who is a methodology specialist at NICE, but uh, he gave a message of what NICE does, in terms of not just for NHS, but they also work with other international or other countries and health ministries, helping them develop guidelines. And
sevens and what was best practice. There was a paucity of polystyrene.
yeah, so
Hello, my name is Hugh McGuire and I'm a Senior Scientific Advisor at NICE International. I'd like to thank Dr. Narayanan for the kind invitation to present this video to you today. And I will be talking about how NICE develops guidelines and supports the implementation of these guidelines in the NHS. To start with, I'll take you back to 1999 when NICE was created. And this is the context back then. There was a huge amount of evidence being produced, and there was no guidance for professionals on what to do with this evidence and what was best practice. There was a paucity of quality standards. The uptake of innovative technologies and practices was slow. There was huge variation in the nature and quality of care being provided, so-called post.
yeah, so I basically they are helping us also in our process, and at this time we are taking their help in the next series of workshops. And this was in brief what I wanted to mention about IHOPE's work. But happy to take questions, and over to you, Dr. Ravindran. Thank you so much.
Thanks, Raja, for this brief introduction. I also really appreciate the leadership of LV Prasad in taking the initiative to put together this organization to improve the clinical research in our country. That will definitely go a long way in improving the healthcare and the outcomes, especially, and also bring a certain level of standardization in the care we deliver to the people across the whole country. And in that, it's also good to see the IAM joining. Always the management plays a much bigger role in anywhere, whether it's a health or education. And we also have the Public Health Foundation of India joining them. And I think the important collaboration is with the NICE, who have all the expertise. We don't have to reinvent. And this has taken shape. And the first thing that they have come up is also coming up with the standard guidelines for ophthalmology. And the work has started. But earlier, the government also had taken this step. Earlier, the Director General of Health Services, along with FICCI, they came up with a guideline for ophthalmology. So, and later, again, the NICE worked with NSHRC, which is the National Health System for Resource Centers. They also had come up with one guideline on dry eye, where I was personally involved, and Abba was one of the instructors, and they really reviewed all of that, and it was a great learning experience for the people who were involved. I think from learning from that, I really understand how we can really translate the clinical knowledge into research and make sure that everybody understands the steps which they can follow to make sure that the patients get uniform care. So would like to see this grow in the coming years, becoming more and more popular. So with that, I request Dr. Namrata Sharma to talk about role of All India Ophthalmic Society in guidelines and advocacy. Dr. Namrata Sharma is one of the senior professors and unit chief at All India Institute of Medical Sciences, and does a lot of service to the All India Institute as a general secretary. Now she's going to be the scientific committee secretary for the next 3 years. Dr. Namrata.
Slippery. Okay, thank you, Raja, for inviting me for this session. And I think this is a great session, especially because it talks about the guidelines. Now, I am going to be talking to you about advocacy and guidelines. What is the role of All India Ophthalmological Society? Whatever guidelines they come out through the All India Ophthalmological Society, maybe they don't have any regulatory role, but they do have an advisory role, and the various other organizations do refer to these guidelines in case if there is any controversy or in case there are any legislations, etc. And they do help our members also in that way. So, as the leading professional association, it does play an important role in promoting and advancing the interests of the profession, and they can advocate also for policies and practices that can improve eye health outcomes in the country. AIOS does play a key role in developing and disseminating the clinical guidelines by the ophthalmologists in India. Uh, as far as advocacy is concerned, it does raise the awareness about the eye health issues. It educates the policymakers, the healthcare workers, and the public about the importance of the eye health. It promotes policies and practices that can improve eye health outcomes in India, and also indirectly reduces the burden of preventable blindness. Now, we have been developing and disseminating guidelines. Sometimes they are done in a more planned manner or a structured manner. At times, they are done as the need be, and sometimes they are done out of crisis management. Standardizing the clinical practice is required to ensure high quality, evidence based care. And like I said, regulatory role is not there, but advisory role is definitely there. So, for instance, when the end ophthalmitis guidelines did come up, they will guide the AIOS members on what is the minimum that they should do, and these guidelines are made very loosely. We don't try to be very strict about everything, because we know that once you write a statement there and say that this is mandatory, then somebody can catch you on it that this was not done and this has been written mandatory. So a lot of advisory, and preferably this should be done like this, is the way we put it in the guidelines, except for the things which are really very essential and which you can't let go. So these are just to give some examples. This year we published guidelines on intracameral drugs in ophthalmology, because lots of intracameral drugs, including moxifloxacin, uh, is an off-label use, and even the manufacturer will not say that this is fit for use intracamerally. But if you come up with these guidelines and our members are using intracameral drugs, and if there is a adverse event, then at least you can justify that these were dealt by, and these have been given by expert group from the All India Ophthalmological Society and have been vetted by them. So we do come up with these guidelines, and very soon I think we are going to come up with the off-label use of off-label drugs and ophthalmology guidelines, which is again going to be helpful for our members. Now, there are some guidelines. For instance, in this, there was this consensus statement regarding pediatric IO examination, then on primary angle closure glaucoma. Some of them are more clinical, like primary angle closure glaucoma or open angle glaucoma, that were done by the AIOS. And I think very important, although this is not a guideline, is the informed consent books that have been done for ophthalmic surgeries to help the members. And they have been translated into various languages, because you're supposed to take consent in the language of the patient knows, and they have been done by several states. And again, like I said, they don't have a regulatory role, but it kind of gives a template. You can customize it according to the way you want it. As far as advocacy is concerned, this is the step that we took. Then that was exemption from registration of ophthalmology scan A and B and UBM under the PCPNDT Act, and this still exists. There have been 2 or 3 hearings in the court for this, but every time this is still there, and it has not been dismissed. So this is the stay order by Honorable High Court of Delhi to say that this has been exempted as far as the ophthalmology scan is concerned. Then, as far as recognition of eye clinics as daycare centers is concerned, at the level of Delhi Ophthalmological Society, again, this has been done and the process is continuing. And I'm sure even if a single state gets something on the recognition of eye clinics as daycare centers, then all the other states can use that document to to replicate it in their states, and at least to reproduce it and use that as a precedence, so that it can be done in their states. Then likewise, there was a GST on refractive and LASIK surgery, and again we represented to the Department of Excise that this GST on cosmetic surgery, they were wanting to levy, but as of now it is not there. I don't know whether it is there in all the states or not, but at that time measures were taken so that this was exempted, because refractive surgery is not a purely cosmetic surgery, it has a therapeutic role also. So, rationalization of rates for ophthalmic surgery procedures under the Ayushman Bharat Yojana. I think I would like to recognize the efforts of Dr. Raja Narayanan in this. We helped to formulate the guidelines so that the charges could be increased a little bit. Though we did succeed partially, but not completely in this, and I think uh, it is important to have the representation there, representation of the correct people. Sometimes people who are representing ophthalmology in these kind of committees or meetings actually do not have idea. Like, just to give some example, and this is off the record, that if you have people who are not operating into this committee of Ayushman Bharat Yojana, fixing the rates for the surgeries, then it's not done, because they wouldn't know uh, that they have to fix a lower or a higher rate. Plus, if you take people who are only from the government organizations, then possibly they don't spend a lot of money on other peripherals and other things which other private practitioners, whether solo or group practice or charitable institutes, would be doing it. So we made a document where we took 3 or 4 representation, one from the solo practitioner, one from a group practice, one from a charitable trust, and one from government organization, and placed the rates of all those and took an average of what it should be. Of course, it hasn't gone through, because they say that when the rates are going to be revised, they're going to look at it. But this is important, and unfortunately the government of India and the Ministry of Health and Family Welfare, when they make their policies, they don't include the societies, but they include the institutes. And it would generally depend on who's being representing there, and whether he's able to take the call of the ophthalmologists at large or not. Now, in the COVID-19 initiative, we did come with the various guidelines on which were on various specialities. One was OPD management, OT management, then how to deal with the retina cases, the glaucoma cases, the cataract cases, the oculoplasty services. And these were dynamic guidelines, because as the COVID situation changed, they had to be changed again and again. Now, this was a representation which was done to the Honorable Finance Minister at that time in COVID, only because people were not able to pay their EMIs for the instruments that they had purchased. They had given FDCs, they had given PDCs, sorry, and these had to be, honored for a prolonged period of time, because of the COVID situation, as the finances for our members were not up to the mark. So it did work out. At that time, we didn't know what we were doing, but every possible measure that we took actually worked out. And then there was a sample for force majeure letter for the landlords, especially for those practitioners who were practicing and had to pay their rent, and needed a deferment of the rent because the practices were not happening. Then to the industry partners, we appealed, 164 in number, to support with the deferment of payment, extension of AMC and CMC during the period, and to extend the warranty, etc. So our partners also relented. Like I said, somehow whatever we tried in that period actually did work and did give results. It doesn't happen always. Then representing to the telemedicine, for the telemedicine practices guideline, that telemedicine should be allowed, and simultaneously it did happen that through telemedicine also people could see patients. Then representation to the IRDA regarding the clause subject to exclusion of communicable diseases in the professional indemnity policy, that was done in 2020, and this communication was received from IRDA regarding the withdrawal of the clause. Then representation also to the ministry for the same, and these were the operational guidelines of COVID-19, the telemedicine practice guidelines which came, then representation to the Director General to provide immunity to healthcare providers during the pandemic. So to conclude, AIOS, I think why AIOS, any society which is for the medical fraternity, has an important role in advocating for policies and practices that can improve the eye health outcomes in India, and leveraging expertise and influence to promote better eye health outcomes for all Indians is what we are looking at. And this cumulative effort would lead to reducing preventable blindness in the country. Thank you very much for your kind attention.
Thank you so much, Dr. Namrata. In fact, you've shown how much work you have done also in actually, communicating with the health ministry and various other authorities for the sake of our ophthalmology community. I just had one question when you mentioned about the Ernst and Young costing exercise which was done. I think it was a very important exercise. A lot of insights came from that. Um, what has been the next step in the sense, does it require any further follow up with the government, and how can we improve the overall packages pricing?
So there is a committee, Ayushman Bharat committee. I mean, I don't know the exact name, but a committee which deals with the prices of all this. And when we had made that document way back in 2020, they said that we've just released the rates of Ayushman Bharat, and when they do it after every almost 2 years, if I'm not wrong. And they said when we take it up in the next committee meeting, we'll surely take it up. But I don't know if the meeting is already held. Possibly, I think there was a document which you had also floated, Raja.
That was
one has
last year,
to-
so maybe next year they
maybe
might
next
take
year
up.
they might just take it up. So
Yeah.
somebody needs to follow it up.
Dr. Abha, you have any comments or anything?
Under that, but I can find out because they did look at that costing data and did a cost price differential from the HPP 2.0 before the revisions were made in 2022. And interestingly, and I was really enjoying listening to you, there is also an exercise that we have done looking at current cost accounting practices in India and the willingness of providers, both public and private sector, to share cost data so that better price setting can be done. Because there's always this contention that the prices are not reflective of what the market price should be. So that study should be out maybe in a couple of months, and I'll share that paper as well.
So very nice presentation, ma'am, and I'm so happy that you brought out that point of price fixation, because when you have these national policies, I remember being a part of it when Ayushman Bharat was fixing the rates for retinal surgeries. And this is exactly the problem we were facing at that time, that the majority of the representation in that particular meeting was from government organizations, where they have not really put in any investment in the equipment. And what happens is that unduly brings the pricing to a very low level, which is not acceptable to majority of the private practitioners. So I think this is something we are really going wrong whenever we are having these pricing being fixed. There's not an equal representation of all the category of the clinicians or who are dealing with the public.
Yeah. So what happens? They'll just call somebody from Safdarjung Hospital, or they'll call somebody from RML Hospital, and for them, it's done. And just to give one example, pterygium at the cost of 75 rupees is not done. But somebody would have told them that there's nothing much to it, you just have to remove it. But nobody told them that you have to do a auto conj, fibrin glue is required. So I think it depends a lot on actually who's representing there. And several times, at least on 3 occasions, we've gone to the Ministry of Health and Family Welfare, told the Secretary Health that please call some representative from the society, because the person you are calling is not representing everybody. But I don't think they do it. I mean, they've never done it. It is always that we've had to represent, and then some partial relief has come, not even complete relief.
I remember they suggesting that there should be absolutely no cost for doing a pan-retinal photocoagulation for diabetic retinopathy. I mean, if you come to such things, then I don't think anybody will entertain any patient in their clinic.
So this costing we had done with ENY, and Dr. Mahipal Sachdev was the president at that time. So we had taken the representative data of all the categories of hospitals that were there.
Yeah, thank you so much, Dr. Namrata, and it was a wonderful talk. I now invite Dr. Anthony Vipin Das, my colleague at LVPI, and also the champion of EMR, not just ophthalmology, but I would say he has his thoughts and vision for. So, yeah, as I was saying, he's a visionary leader in electronic medical records. He'll be talking on big data in ophthalmology. Over to you.
Yes. Thank you, Dr. Adi and Dr. Arun, for the opportunity, and good afternoon, everyone. I'm Dr. Anthony Vipindas from the LV Prasad Eye Institute, and today what I'll aim to basically showcase is the digital journey that we've undertaken about 13, 14 years ago. And the LV Prasad Eye Institute is the eye health pyramid, where we basically have the vision centers that are all networked to the Center of Excellence of about 275 centers. So over 14 years, what has happened? We've reached a milestone of about 11 million patient consults in over 7 countries, with about 4,500 users using the system on a daily basis, and also about 12,000 patients moving through the system every single day. And it's not just in India. We are in different parts of the world, places that most of the digital solutions would not basically be. And we want to kind of go and add value to specific regions in accordance to the data regulations of those particular countries. And of course, as I mentioned, we crossed the 1 crore patient mark recently. And not just that, we're happy to share that we are now also a Harvard Business Review case study to kind of share our experiences of what we have digitally transformed LVP over the past decade as well. So the system basically is quite diverse, right from the tertiary centers to secondary centers, all the way down to the vision centers and also the vision guardians. All of them are capturing data points, right? So what we've done is we've integrated all of this into a single particular solution. And it's not just data, it's a lot of images also that get, because the eye is an external organ, you do have the ability to kind of share these for teleophthalmology consults by our vision technicians on a daily basis from across 3 states of India. So data, basically, if you look at the possibilities, there's clinical data that you can mine, there's media that is basically images, there's financial information, that's health economics, and also operational data in terms of efficiency of processes, right? But there are challenges also in healthcare, right? So data is not available, standardized structured data is not available, and you need it in continuum. You can't take a data set and then basically say that, okay, this is my experience at this, because it constantly can probably change the next year. You need to know the trends, and it's also time dependent. It's basically you have to wait for a response basis your intervention, and also standardization of input of information also is kind of a big challenge. But I just want to kind of highlight the kind of data point and its characteristics, right? So there is volume, and all of these characteristics are conducive to ophthalmology, right? So we have the volume of patients, we have the velocity of the churn of patients, we have the veracity of the different geographies they come from, and the variety of data as well. But then we need to derive value out of it, right? So this was a perspective piece that we put in about the promise and challenges of big data in the Indian Journal of Ophthalmology. But there is a spectrum of the studies that you can do. So descriptive studies, diagnostic, predictive, and prescriptive. But what is very important and foundational is that we need to understand what our Indian population and the cohorts and the kind of distribution of diseases, before which we look at outcomes, and then we look at predictive modeling, and then we look at prescriptive, telling you which is the right treatment. So it is a stepwise process that we need to kind of take. So there were 2 questions that we at LVP said, hey, can research be in real time? When I mean to say that, it's not like I did a study 3 years ago and this is my thing, but can it actually be a data pipeline that continues to generate insights because it's digital data, and also bridge the gap in human understanding? And you would basically agree that there is not much in Indian literature for most of the other diseases. When you try to say, hey, what is Coates, and say what is Lawrence Moon Beetle, you don't have that, right? So we basically said, can we start from building that? And we kind of put all of this into the AI project, which is on ResearchGate. But also, just to kind of let you know, it's not the high flying tools. There are simple tools you can also use to do big data analysis, right? So we use MySQL and PHP, Excel sheets, R and Python. Our researchers use that, but we also visualize data, because what's important not just to analyze but also to be able to represent it in the right format. I basically always show this slide of the evolution of the data set. What I mean by HKMBT is that we used to do studies in the 100 patients, like you had 100 patients and it was a great study. You had collaborative, more data points from different institutions. You probably were in the thousands, but we've moved into the millions right now, right? So, and what you understand at 100 is different at what you understand at a million. And we're trying to see in healthcare, can we move to the billion and the trillion data point? It is possible, but it's kind of a collaborative, collective effort of what we can do together. And this was our first experience of publishing the 8-year retrospective review on the iSmart database in about 4.7 million consults. And now our unique patient cohort is about 5.1 million consults, and it's kind of growing by the day at LVP. And what we've been able to do over the past 3 to 4 years in a very, very methodical manner is we started to lay down these descriptive papers from this large data set of 5 million patients, right? And we're basically trying to put in what is the presentation of patients, outcomes, what are the kind of treatment patterns that we are basically giving to these patients. So very quickly on each slide, I'll just probably show you what was our intent. So for dry eye, we basically looked at what was the risk factors. And this is the largest dry eye study in the world, about 21,290 patients. We found that increasing age and higher socioeconomic status had a higher risk. But in allergic eye disease, we actually saw a very clear pattern of presentation of patients during the summer, for which now we basically start preventive care. We looked at risk factor of how being close to the equator for the development of a condition which is the pterygium. We also looked at, if we do a corneal transplant, what is the prognosis? So using the Eye Bank Association of America, we basically kind of looked at what were the indications for what we were doing keratoplasties. As you know, LVP is the largest keratoplasty center in the world, but to our surprise, we found that fair to poor prognosis for keratoplasty was seen in about 60% of the graphs that we were basically doing. And not just that, we visualize data. We use certain tools to basically do multiple combinations. Like in a paper, you can just have a table and a set number of combinations, but using visualization tools, you can actually select multiple combinations as well from your data set. And not just that, what we've been profiling is an entire 0 to 100 year decade experience of the cohort of patients. It's not just one specific pediatric age group or the middle age group or the elderly, but every disease profile is going. And not just that, severity of presentation of disease in different decades also we're kind of exploring. And more importantly, we are also mining textual information that you write. I'll show you in subsequent slides. So structured data is easy to mine, but there's a lot of other unstructured data also that where a lot of if I say gold is right there, because you crystallize all of that and you write it in one paragraph. But this was an example where we specifically looked at consanguinity and ocular disorders, and looking at which were the disorders that had the highest rates of consanguinity. Shed actually had 100%, and xeroderma pigmentosum had the highest for affliction in the families. But not just ocular disorders, we are also delving into very complex outcomes for surgery, because we've been lucky to kind of have these templates that we put on a decade ago. And now what we're doing is we're trying to things like scleral tear repair, orbital fractures, eviscerations, strabismus surgeries. We're just going more deeper into more complex surgeries to actually look at outcomes as well. And moving beyond, we also have done a little bit of multimodal data. What I mean to say is that we've also looked at, because the eye is an external organ, it's exposed to the environment, so we kind of overlaid a little bit of weather data that we received from the Telangana government. And we also looked at comparison of EKC and MKC, their peaks. But not just that, especially when the COVID was going on, people thought summer is going to come and COVID is going to go away. But we just thought, what is the effect of specific rainfall, humidity, wind speed, and temperature on presentation of EKC patients. We found no correlation. But what is very satisfying, if I may say, is this one slide. We've gone and put our system in Liberia. We've started the Liberia Eye Center in 2017. But what is very exciting is the government gets to see this map. It gets to see what patients are suffering from, right? And so in a war-torn country with civil war and Ebola and everything, we do have the ability to basically take our systems and add value on the ground. So at Liberia, we basically have iSmart running, and it's constantly churning out insights for the government on a daily basis. But not just that, when COVID-19 happened, and we basically tried to put our experience as much as possible. Very thankful to IGO for all their support, because we were trying to just understand what was happening to ophthalmology, and a large network like ours shutting down, what were the vulnerable groups. So we kind of really published a lot in terms of vulnerable groups that we found in diabetic retinopathy, endophthalmitis, all the acute conditions of people coming to the LVP network. And we basically looked at pre-COVID, lockdown and unlock, what was the kind of proportional change of patients. Not just that, we also looked at intra-city, interstate, intrastate, and also international patients. What was the kind of change in terms of the proportion of presentation to our network? And not just that, we also operationally looked at when did we kind of reach back to pre-COVID levels. It's just for our understanding to know what was happening, right? But I want to spend some time on this slide to show you what is unstructured and structured data. And you can basically see the slide. iSmart basically has almost 70% of structured data, which is very exciting, because when we extract, you do have a lot of structure that basically is extractable for ease of analysis, but also there's a lot of unstructured data. And even for that, what we've done is we use certain data science tools. In this particular case, we try to look at the systemic disease distribution and its effect on certain ocular diseases like ARMD and diabetic retinopathy in about 600,000 patients in an automated fashion, to basically look at the frequency and also the duration. I just want to highlight the AI pipeline that we published this a few years ago, but just to kind of bring context, it's not just about machine learning and AI and everything. First is, where's your data? First point is you have to digitize. The second point is not just put one text box and call it an EMR. You need to have structured data, right? And the third is where most of the world is, publications of AUC, all the, sensitivity, specificity, but you need to bring that back into the point of care to the doctor, right? And then you need to quantify the usage. And people now are talking about ETAI, which is ethical and trustworthy AI, right? So why should I trust the AI if I have, 10 or 20 years experience behind me, right? So clinical validation is everything, because once the patient leaves your clinic, there are many other environmental factors and factors that are not under your control that also have a play in the outcome. But you need to learn from that and then, modify your step number 2. So this is a continuous process. Our ethos is that it is a constant learning process of care, right? So as Dr. Raja has mentioned, we've been, grateful to, bring this research and policy center to shape with the collaboration of, many wonderful institutions. We'd encourage you to kind of follow our updates at IHOPE2020.org and also, join the community. So next is what, as I said, descriptive, then prescriptive in terms of outcomes, and predictive and health economics and operational research. But I think what is very exciting is discovering what you don't know. It's into the unknown. What our approach for big data is, there's no predetermined hypothesis. We just want to understand the pattern, because the kind of scale that we have and what we are mining, we just want to understand what exists, because now the world is moving towards real world evidence and real world data, right? And ethically also, there are concerns that you might not want to give a treatment when a patient actually deserves it. So I think this whole concept of, large scale data will really kind of aid us to, but I want to kind of end on this one particular slide. You all would have seen it, but after all of this that we do, all the millions that we talk about, it's GIGO. It's garbage in and garbage out. And today I can confidently tell you that 10 to 12% of the data is noise. But we do have the luxury to, just take 70,000 or 50,000 patients and say, okay, we will not use them because they're not, in terms of the inclusion criteria. But it's also a continuous process. We do have audits in the organization that are constantly looking at the input of information as well. And it's very important for us to be mindful that what you input is what you get out, right? So that discipline also is something that comes with time, but it's very exciting to see how in India we are now evolving specifically in ophthalmology, and really looking forward to working with our organization. So I'm available at this email, and thank you once again for the opportunity to be here. Thank you, Dr. Raja and Dr. Adi.
Thank you so much, Vipin.
Happy to take any questions now or later. Thank you.
Yeah, so I just wanted to go off track a little bit. I just wanted you to comment on your contributions beyond ophthalmology now with the NCG, the cancer grid. So how are you helping their requirements in terms of digital health?
Yeah, thank you, Dr. Adi. Arun. The thing with IHOPE is basically policy and advocacy also, right? So what we've been able to do at LVP with ophthalmology, understanding data dictionaries, the pipeline, how you connect, the real-time connections from database, data cleaning, all of that we are now working very closely with the NCG. As a matter of fact, just last week we finalized the first cut of the data dictionary of pulling of cancer data from the NCG network, and it's a very exciting thing what NCG is doing. NCG's vision is very, very inspiring. They are actually they've already rolled out a request for empanelment of EMRs in the country, where they're trying to standardize EMRs which are going to capture cancer care data. But then what our thing is, once it gets captured, what is our dictionary and what is the format? So I think, Dr. Arun, it's exciting to work with them. But again, as I said, what Indian Health Outcomes I think stands for is digital health for India. I know we are starting with ophthalmology, but we are also working with maternal health with Fernandez and NCG, and we're looking at expanding our understanding, and it's a collective learning. And I'm sure in 2 to 3 years, if you are able to bring these very strong examples in the country out there, I'm pretty sure the rest will be able to follow what our experiences have been. Thank you.
Thank you so much.
Yeah, I mean, just one question. I mean, it's interesting to see this with the big data. You have presented a lot of the cross-sectional studies. So you have any longitudinal study, to say that somebody came with this much of myopia 8 years back, and what is the status now? Is there any cohort of patients whom you have followed in the last 8 years to say that, which of these patients can progress, their myopia can progress, or their glaucoma can progress, or DR can progress? Is anything has been done that way?
Thank you, Dr. Ari. Wonderful question. There is one which is already ongoing for myopia, as you mentioned. Okay. And as a matter of fact, about 3 years ago, we set up the Infor Myopia Center, where now there's a prospective capturing of information of even risk factors or other factors that might affect outcome outside the hospital as well. So Dr. Pavan Vakichala, my colleague, is doing that. And also, Dr. Adi, let me be open about this, is that I think there's been an internal awakening of what you can do with data, with digital health, right? Because this whole journey for a decade for us, just the past 4 years, for us to basically go back and look at this cross-sectional information has given now ideas for consultants, as you mentioned, to kind of start this prospective collection of information as well. So I think in the next few years, we will also kind of see the ability to monitor disease progression, identify vulnerable groups that might be at risk for poorer outcomes. But I think we have started, and that's where we want to build on to able, so that's what I thought is the natural evolution of this process. Thank you.
Yeah. It would be good to know if as they're building this auto refractometer, that data also can give axial length data, or maybe few other data.
Oh yes, they are.
It will become valuable, I'm saying.
Absolutely, they're capturing not just that peripheral refraction values, everything that basically putting it in. So that's a very interesting longitudinal data set that Pavan is building right now, and we're excited to see what will come in a few years from now.
Yeah, in fact, they're adding other data points also, as was mentioned, the screen time, daylight, how much exposure is there, and many other factors. So I think it would be interesting in the next few years to look at the longitudinal, basically looking at predictive analysis.
Yeah, predictive analysis. I mean, that's where we have to, the whole real power of big data analysis is there. So.
Yes, Dr. Adi. Yes.
Yeah, thank you so much, Vipin. And now I invite Dr. Abha Mendiratha to talk on introduction to health technology assessments. Over to you, Dr. Abha.
Thank you, Dr. Narayanan. So I'll be talking about health technology assessment and how can it also feed into some of the decision making, including the use of clinical guidelines. Maybe before I start, how many of you are already familiar with the term HTA? Oh, okay, so that's good. So I'm speaking to the converted, hopefully. So it's going to be a short presentation. So we are often faced with the problem of scarcity. I think it's very obvious in a setting like India, where you have so much of diversity and so much of inequity. And we often have situations where there are limited resources, but there are unlimited wants, and we have to choose between what the patient can actually afford and or sometimes what the government can actually afford to provide. And the question is that when we have two options to choose from, how do we allocate scarce resources as efficiently as possible to maximize the value and the benefit that the patient would get and the health system would get, because every rupee that we spent once cannot be spent again. So we need to do it wisely, and that's where health technology assessment comes in. So what is HTA? I think very importantly to say, it's a multidisciplinary process which uses explicit methods, very transparent and clear on what is being done, how it's been done, to determine the value of a health technology, which can be done at different points in the life cycle of the health technology. But keeping in mind that it's not just an academic exercise, it's not just for research, it is actually to inform decision making, so we can promote a system which is more equitable, more efficient, and a high quality health system. Few things I just want to add. I know there's a lot of small text, but it's not for you to all of it for you to really pay attention. But I just want to mention, and I saw that there was this very big what is it called, market fair on the left side, and I was trying to find my way to this hall, and I got lost over there. I was quite overwhelmed with the number of technologies that were in display over there. And HTA can be used for any kind of technology to either prevent or to diagnose or to treat medical conditions or to promote health or even rehabilitation. And often the term technology is thought of as something very, diagnostic or high end, but it could be as simple as a health program. It could be a device, it could be a medicine, it could be a vaccine, or even the way a system is delivering an intervention. So the way the technology is defined, it's quite open, and a large number of interventions are included. It's very important to say that it needs to be systematic, transparent, participatory, and formal. We heard a lot of discussion in the earlier presentation about prices being set, but the process was not transparent or participatory, and then the decisions that come out are not acceptable. So for the HTA process to be legitimate, it's very important that the deliberation is done in a manner that the decisions are acceptable. And when the HTA is done, again, a misnomer is that often it's thought that when we're doing an HTA, it's all about economic evaluation, it's about cost effectiveness, it's about cost reduction. But really, an HTA looks into all the dimensions. It looks into clinical effectiveness, the safety, the economic implications, the cost, as well as ethical, social, cultural, implementation, and legal issues that can arise if that technology is introduced into the health system, and looks at intended and unintended consequences that can take place. So how is HTA process be carried out? And I'll give you a generic process and then speak more specifically on how it's being done in India, and maybe open it up for maybe discussion from all of you in terms of how this applies for ophthalmology and how you can leverage that. So the first part is really to get the right topics introduced, because as I said, there are, I wouldn't say unlimited topics, but there's a very large number of topics and new technologies which are interested to be at least introduced in the public system. And there needs to be a priority setting even for how we are choosing the topics on which an evaluation or an HTA is going to be done. So defining the decision space is very important, and prioritizing topics which are addressing unmet need, are a high priority to the health system, or it's a novel technology. And usually HTA agencies have explicit criteria on how they evaluate topics, and they also need to be quite transparent if they say no to a topic which they refuse to get to evaluate. The second step is the actual analysis, which can include the cost effectiveness analysis, a budget impact analysis, even extended cost effectiveness analysis, which takes into account equity as well. But after the analysis done, usually by an academic center, the evidence that is generated needs to be appraised, and it's usually appraised by a multidisciplinary team which looks into the strength of the evidence, and it comes out with recommendations as well as very explicit argument on why certain recommendations were made, which could be favorable in terms of recommending the recommendation or against it. It depends on how much power the appraisal committee has. Often we find that there is a different body which actually makes the final decision on the implementation of the technology in the health system. And in India, that becomes even more apparent because health is a state subject, and you have different decisions being made by state governments, by some of the national programs, and then even at the national level, you have the National Health Mission, you have the National Health Insurance Program. So it's quite a complex, pluralistic health system with multiple decisions being made. And largely when we talk about HTA, we are really talking about its application and its use into what the public health system funds. But I think that raises questions in, again, a pluralistic health system like India, which has so much of private sector participation, where ultimately many of the decisions are made by the patients themselves. I think it really opens up a question that how at least we can have better information available that comes out from these HTAs for providers and patients to take better decisions, because some of our decisions are so decentralized. So the health technology assessment, once done, to help ease its implementation, it is often woven into the recommendations within clinical guidelines. And then key recommendations of clinical guidelines can be extracted to develop quality standards and indicators, which we can monitor through the EMR system that we were hearing about earlier. And then you can have other levers like the health benefits package, education through the professional organizations, accreditation and regulation to implement and to support the use of the HTA into the actual service provision. So HTA is very widely used. We see that many countries have been using it for several decades, and it's a relatively younger program in India, but India has also come quite a long way in the last 5 to 6 years, and my second slide, I'll be talking about that. Maybe I'll share this slide because it has a specific ophthalmology example. So you have a lot of, we heard about NICE being discussed. So NICE actually started out in the 1990s as an HTA program, though it's much better recognized for its clinical guidelines program, which came much later. And the reason why the guidelines program came because they really wanted the HTAs to inform decision-making of professionals. And they felt that just giving them the HTA recommendation was not good enough. It needs to be linked into the treatment pathway or the clinical pathway for the patient. And that's why the clinical guidelines program came in. And over a period of time, it's now a legislation, and as per, after 2012, the HTAs that are produced, it's mandatory for the NHS to fund them if NICE gives a yes for that recommendation. And these HTAs are woven into the clinical guidelines, and the clinical guideline recommendations are not mandatory. But every country is different. I just want to say there are lots of examples on the slide, and India has its own way of doing it. But just as an example, that the HTAs are legally binding in the UK. We also have in our region have a very robust program which is run by HITAP in Thailand, where HTA directly informs what the government procures in their essential medicines list, as well as what gets covered under their universal health coverage scheme. So the final decision is made by the Ministry of Public Health, and they can say a no to a recommendation that comes out. So it's a different system. The recommendation that comes out from HITAP is not a binding decision, unlike NICE. They can say a no to a recommendation from HITAP, but they cannot say yes unless an HTA has been done by HITAP with a positive recommendation. So that means that the evidence is very important when they are taking a decision on what the public system is funding. So just to give a brief overview that while few people know about it, HTA has been in discussion for more than a decade in the country. And it started out with its mention in the 12th five-year plan. And there was a commitment made by the Parliamentary Standing Committee way back in 2013, about 10 years back, that they would set up in the next 3 years the Medical Technology Assessment Board, by which they would look at evidence in terms of cost effectiveness, clinical effectiveness, in terms of new technologies that the government decides to procure. HTIN was established in 2017. It was initially a program in the Department of Health Research. And before it was set up, there was a very wide stakeholder consultation done by the Ministry of Health, where all the key arms of the ministry, which included the Department of Health, the Office of the DGHS, and the Department of Health Research, along with the Health Minister, with a strong commitment that they want to use HTA in decision-making for decisions in the public health system. The work that HTIN has been doing, it now has a network of 18 regional resource centers. I'm not sure which one is, yes, there's one in Kerala as well, and it's in Trivandrum, and forgive me, I'm forgetting the name. It's Sri Chitra Tranul is one of the RRCs in Kerala. And these 18 centers are geographically spread all over the country. And publicly funded organizations can currently submit a topic for evaluation to HTIN, and the topic gets prioritized, and after it gets selected, it gets sent to these regional resource centers for the evaluation, and then the appraisal and the final decision is made by the board of HTIN. So this is what I was saying, that if there is interest in topics in relation to ophthalmology, you can directly submit if it's a publicly funded hospital, or it comes through a publicly funded Department of Health or a state government. You can send the topic, and HTIN has its process through its 18 regional resource centers to commission the analysis, and then the appraisal is done by the Medical Technology Assessment Board. The board gives a recommendation which is not legally binding, and the final decision is then made by the state government or the national government, which actually gave the topic in the first place. But we're also seeing that because there are multiple decision makers, and some of the decisions are applicable. For example, the state of Punjab may have given a topic on safety engineered syringes, but it's also applicable for other states. We are seeing the uptake of the recommendations by different users besides the person who gave the topic in the first place. I'll briefly talk about adaptive HTA. So we do know that a full health technology assessment takes at least a year and a half sometimes, which can be a challenge in terms of resources in LMICs. I do want to mention that there is quite a bit of capacity which has been built over the last 6 years, and there are close to about 100 people who are currently working as a part of the HTA ecosystem. So I don't want to underestimate that, but even then, India is a big country with lots of clinical specialties and questions and technologies that need to be appraised. There can sometimes be an issue with limitation in the availability of the cost data. I'm finding that, sorry, the font is all skewed in the slides. I don't know why. As well as limitation in local epidemiological data. And that's why the need for a more pragmatic process and how we can leverage available international evidence where other countries may have done a health technology assessment on a similar topic, being aware that we're talking about different health systems which have different costs, and how can we develop methods which can then make adjustments for the costs in India. So this is some innovative work that we started initially with the National Cancer Grid. There are about 14 policy briefs, some of which have directly informed the inclusions of the Ayushman Bharat, the PMJY health benefits package. And the methods are also now directly linked to the guideline development for the National Cancer Grid. So the clinical guidelines explicitly mention how economic evidence, including the adaptive HTA methods, will be used for them to, and taken into account when they are developing recommendations. We're currently working with the NHA on developing a more national and accepted method for adaptive HTA across clinical specialties. So I'm hoping that, and there's been a lot of refinement and learning from the work that we have done with the NCG that has gone into that. So this is my last slide. I think it's really about how can we integrate HTA into the broader Indian health system. I did mention that traditionally HTA has been used in publicly funded health systems like the UK, but India is different, and we need to have our own unique answer and really look into why, while we strengthen its use in the public health system, maybe how at least some of the information that comes out from the HTAs can feed into clinical guidelines which are relevant for both the public and the private sector. So I'll pause over here for questions. Thank you.
Thank you so much, Dr. Abha. That was, I would say, a very, very informative talk, and most of us in ophthalmology are not aware of what's happening in this area in India. But I think there are so many questions, but we are absolutely short of time. But I think after the session, maybe we will have another session with you. But in the interest of time, I now invite Dr. Manisha Agarwal to talk on VRSI guidelines in DR.
So good afternoon, everyone, and thank you, Raja, for making me a part of this entire exercise. More than the VRSI guidelines on DR screening, I think my talk would be to really highlight that what is the relevance of developing certain national guidelines, not only for the ophthalmologists, but also to rope in diabetologists and physicians who are very often dealing with more diabetics than what we are. So, just a case example to begin my talk that where the relevance is. This is a young 45-year-old type 1 diabetic and on dialysis for 2 years. And he's apparently the sole earning member of his family, but not able to work and in severe depression just because he's not able to support his family. And this is very often the clinical picture of the patients that we are seeing day in and day out in our clinics, feeling extremely helpless that we are not really able to do much, and why these patients are not coming much earlier to the eye hospitals or to eye specialists. So now, if we really go back and question ourselves, this patient apparently has been under the consultation and care of a physician and now under a nephrologist also to add to the list for last 2 years, but has never been advised a fundus examination. And if I was to question my colleagues, yes, they surely forgot something in the entire exercise of managing his diabetes and managing his more relevant complications in their list, such as the kidney disease secondary to diabetes, their neuropathy, and somewhere down the line, probably the diabetic retinopathy falls in the low priority list, and that is why it is very often missed out. So, a timely screening for DR by a fundus examination may have actually prevented the progression to a severe stage of PDR, which is actually sight threatening and causing loss of vision, where we know that diabetic retinopathy is the most common cause of preventable blindness in the world. And if we were to see the global estimates of diabetic retinopathy, we know that already 1.85 million people are blind secondary to diabetic retinopathy, and which, of course, is a humongous number of the blind people. And if we were to see the statistics of diabetes in India, again, it is having an exponential rise, where we are expecting that about 134 million people are going to turn diabetic by the year 2045 and about 100 million by the year 2030. So now we keep hopping over these figures saying that diabetes is on rise. We keep having a lot of campaigns all over in the social media that how to prevent diabetes and all, but nobody really is talking about that when you have an increase of diabetic patients, you're also going to be having a parallel increase in the number of patients suffering from diabetic retinopathy, and which of course is again a preventable cause of blindness, but what it needs is an early intervention. And when we see the figures of the number of patients having diabetic retinopathy in India, the prevalence is as high as 20%, which again is an extremely high what has been reported in the literature. But what is very harmful or what is very disheartening is that 45% of the patients with diabetic retinopathy who are attending the eye units have already lost their vision before the condition actually was diagnosed. And this actually highlights the fact that too little is being done. And even if it is being done, then it is probably too late by the time the interventions are being really done for these patients. And these are a few of the clinical photographs of my own patients who have presented to the clinic, where when we see, we wonder why these patients didn't come into our clinics much earlier. So if we question that why the patients didn't come earlier to us, well, there are no early warning signs of diabetic retinopathy, and probably that's why they didn't feel the need of coming and visiting an eye specialist. We know that diabetic retinopathy is very gradual in onset, and the decrease in vision mostly is in the later stages. And when they present to us, there already has been quite a significant permanent loss of vision. The other question also is, or the other problem is, that despite being referred for a fundus examination, many of them may not actually turn up for a fundus examination, and the reasons could be several. One is that they may be daily wage workers and they really don't want to lose that wage for the day. There may be a travel expense involved, there may be a consultation fees, and especially when they're not having any symptoms secondary to DR, they really don't attach any kind of a relevance or importance for going for a preventive checkup and spending money and not earning for the day. Now, only 20% of the diabetics we know would have diabetic retinopathy, and of these 20% also, only 20% would have actually a vision threatening condition. Now, since we really don't know which 20% out of the entire lot are going to be having the sight threatening condition, we apparently land up examining all the diabetics, and that is what we actually will be required to do. So, the need of the hour would be that we have to do an active early screening for diabetic retinopathy in a diabetic and not really waiting for these patients to become symptomatic. So, the prevention of avoidable blindness due to DR is the need of the hour rather than treating these patients. Now, let me come and briefly touch upon the various activities which have been done by VRSI. And we thought that if we want to bring in any kind of a policy change at the government or at the national level, we will have to target certain specific groups where we can actually convey the message to the health ministry. And these are a few of the photographs where we conducted a screening program for the BSF Jawans in the Ran of Kutch in Gujarat, thinking that probably because the Prime Minister is having a little more sensitivity for Gujarat, probably we could touch upon and take it to a next level. And again, here we have Dr. Kim, the Vice President of VRSI, where we conducted a DR screening camp for all the Delhi police officials, which was conducted again last year, and this again was a huge success. This is another initiative where we had gone and done a DR screening at the military hospital in Jammu last year. And what we see over here, that we are using a fundus camera, which is having an AI-based software for screening the patients with diabetes for diabetic retinopathy. So, what exactly should be done? Screening should be done at every opportunity and need not be really left to the retina specialists, which are just a handful of people. VRSI currently is having around 1,500 members, and I'm sure you would realize that they're not enough to really be screening all the diabetics for DR. So we have to rope in the other categories of people for doing the screening at least, and then probably the management bit can be left to the retina specialist. So we have to find alternative resources, and therefore lies the importance that the screening has to be done by the physicians, by all the diabetologists, and of course the general ophthalmologists, which are forming the much larger volume of the eye specialists. The screening also needs to be done in the community by using technology, like I just showed, a non-mydriatic camera, using telemedicine, or using artificial intelligence. As far as screening by a physician is concerned, when we review the literature, only 1.3% of the general practitioners actually are using a direct ophthalmoscope, which we all know used to be a routine practice where all of them carried it in their pockets. But I think that practice over the years has died down. One, it could be because of the lack of awareness. Second, it could be the lack of time. They apparently have become more busy. The other reasons could be a lack of training for doing a fundoscopy, and of course the lack of incentive. So in today's time, nobody really wants to do something if it doesn't really repay you in some form or the other. So let me talk of lack of awareness of diabetic retinopathy amongst the physicians. And that is where VRSI thought it's important that we do a collaboration with RSSDI, which is the largest group of physicians and diabetologists in our country, having more than 10,000 members. And this is, they have state chapter conferences. They also have an annual conference, and last year they had it in Chennai, where I really had to push myself to deliver a lecture on diabetic retinopathy screening. And what was interesting was that the physicians who attended the conference, and in particular the lecture on diabetic retinopathy screening session, were very inquisitive to know regarding the non-mydriatic cameras, and especially where they themselves did not need to train them, their technicians or somebody else, but it gave a pre-formatted report after doing the screening, and which was AI based. Within few minutes you could actually give the report in the patient's hand. We also developed awareness videos by eminent diabetologists such as Dr. V. Mohan. We all know MV Diabetics is a huge name in Chennai. And probably we thought that the sensitivity and the acceptance levels is going to be much higher if we roped in the diabetologists talking on diabetic retinopathy. So this is just a small video. I'll really not get into the entire video. We also developed posters and other awareness materials for all the members of RSSDI, and we thought that probably if we can just stick these posters in their clinics, at least they are not going to forget that there is something like diabetic retinopathy, which is requiring a regular screening for all the diabetics attending their clinics. We've also plunged into creating several diabetic retinopathy awareness videos, which are all over in the social media. We also conducted a campaign with the FM radio, which was conducted in 49 cities. And we've also collaborated with AIOS, where we have developed an awareness video. We've campaigned along with Network 18 channel, and we developed an awareness video which was aired on their channel for several months together. And this is again a video which is worth seeing, and it's available on the YouTube. We've been conducting these various awareness walks along with AIOS and just spreading a little bit of awareness or making a little noise about diabetic retinopathy. As far as the lack of time and training, we are really wanting to educate the physicians as well as the diabetologists that they can very much do diabetic retinopathy screening without really plunging into the training. And as far as the incentive is concerned, we have been fortunate enough that Ayushman Bharat now has an incentive program for the physician and diabetologist if they are doing the diabetic retinopathy screening, and reimbursement is being given to them, and it has already been implemented in around 25 states. We have also collaborated with 1mg, and BRSI has collaborated with 1mg to send out awareness articles on DR to all their database of diabetics, and they're also conducting various patient support programs and working on other initiatives. We are also conducting various training modules for training general ophthalmologists in 2-tier cities so that they are able to feel equipped enough to do DR screening. And last but not the least, we are working with IHOPE and NICE International, as was mentioned, and we are conducting these various awareness programs and patient engagement programs, again to involve the patients and bringing in more awareness in them. So at the end of the day, we all need to realize that the physicians and ophthalmologists have to work together to bring in the best care for diabetic retinopathy, and it is not possible without joining hands together. Thank you so much.
Yeah, thank you so much, Manisha, for the elaborate presentation on what all activities VRSI is doing, and also there's a lot of work still to be done. That's all I can see from those slides. So in the interest of time, we move on to the next speaker. The last speaker, Dr. Sabyasachi Sengupta, he'll be talking on basics of health economics and insurance. Over to you, Sani.
For 10 minutes back.
Very good afternoon, everyone. First of all, thank you, Dr. Raja, for the opportunity to come here and discuss a couple of important topics to cap off this session. So first thing we'll talk a little bit about is applying health economics in the Indian context. Yeah, so we'll talk a little bit about applying health economics in the Indian context, and economics is something that all of us should really know about, and at the base of it is money, right? So it's important in every aspect of life. So I'm Dr. Sabyasachi Sengupta. I'm a practicing vitreoretinal surgeon in Mumbai. I did my clinical research fellowship at Johns Hopkins about a decade ago. So the real question is it worth spending so much money, isn't it? So Dr. Abha, she had a great presentation, and she also began with something like this: is it worth spending so much? And the question that everyone is asking, the government is asking, the physician, that is we are asking, the patient is also asking. Oh, you're asking me to get this injection in my eye. Is it worth spending so much money, 50,000, a lakh rupee per injection? Is it worth spending so much? So how do we get to to the worth of it? So how do I know, how do I convince someone to say, even though it's expensive to you, in the long run it's worth it, right? So that's really where all this comes in. And let's also sort of, some basics are that the earlier the impairment, the greater the economic burden to society, right? So a pediatric patient will have will be a burden on society for a much longer period of time, and hence will be much more expensive compared to a slightly older individual. So we are really talking about value based medicine, isn't it? So the cost consideration is one part of it, the human or the patient value is one part of it, and there is a financial value to all of this. So how do we tie in all these together is what essentially we are talking about. When you talk about costs, there are direct medical costs, as we all know. It's about inpatient care and other things. There are direct non-medical costs, where a hospital is involved, where starting from housekeeping to so many other things. There are indirect costs, such as productivity loss, and time for seeking care is not there. Like Dr. Manisha said, people are not coming even if they are getting referred, because they might lose a day's wage. So these are all the sort of costs. So we can actually look at it in terms of direct, indirect, as well as direct, indirect medical costs, and all of these are almost the same. So that direct medical cost is the cost of that procedure to the patient, but at the back end there are so many other costs as well, which we need to think about. And it vision impairment leads to increased likelihood of falls, of accidents. There are reduced educational opportunities for the patient. If somebody is a sole breadwinner, it really starts affecting everybody. There's a lot of gender inequity as well. It can lead to depression. So we've heard all of these terminologies in the previous presentations. Let's create real life situations. Dr. Manisha showed us that image. Let's focus for it for a minute. So this is a 52-year-old diabetic with proliferative diabetic retinopathy. He's the most productive phase of his life, isn't it? People are, even if you look at doctors, from 51 to 60 is the time when they really are earning money. There are this individual has he has to repay loans. He's still under a lot of EMI pressure. His children are still getting educated. There is marriage. So, so many settlement costs. He's the sole earning member. Now, what if he loses vision? There is a high likelihood that he might, right? What would you go, or what would you allow the government of India to spend so that it does not go blind, right? And what would the patient be willing to pay to retain his 6x6 vision, right? So can you put a price on this is the real question. Let's say if you think if you bring in your emotion into this, you can't really put a price on this, right? So this is invaluable. This is something that a patient would be willing to spend whatever he has, isn't it? If he knows about this. However, but if you look at it from a scientific point of view, in real life challenges, the trade-off really, so if you look at it from a government perspective, or from a healthcare spending perspective, has to be a trade-off between overconsumption and too little care. It is important to make most of the finite resources. Dr. Abha has already told us this, and it is not enough that an intervention is clinically effective. It also has to be cost effective. So we are bringing in the cost into this as well, right? So clinicians need we are already doing this subconsciously, but then clinicians need to weigh benefits and risks, but should consider whether benefits are worth the resources consumed. So how do we do this? So this is health economics in a nutshell. And the three important terminologies are cost benefit analysis, cost effectiveness analysis, and cost utility analysis. There are many other subtypes, but these are the the three important ones. The crux is these are analytic techniques used for economic evaluation of healthcare, and are designed to compare alternative courses of action in terms of costs and outcomes. So if you have three injections, there is a biosimilar, there's a biologic, and there is a better biologic. Which one is most cost effective, or which one should the government actually spend money on, right? So the choice of technique depends upon depends on the decision they intend to influence, overall influence. So like I said, basic terminologies before we understand these are, first is QALY, that is quality adjusted life years. It's a measure of health as a combination of duration of life and the health related quality of life. Okay, so how long does somebody have to live, and how much are you going to spend over that lifetime is what is QALY. So if you look at this graph, on the x-axis at the bottom there is time. So from 0 to through life, and on the y-axis there is quality of life, where at 0 is poor quality and on top is great quality. What we want is for the patient to be in the blue zone, right? So we want them to maintain quality of life throughout life, right? And the problem is, a lot of patients end up in that red zone where they are old and they have very poor quality of life, right? So how do we prevent all this? How do we calculate quali for this? Usually which is done using questionnaires. So these are many questionnaires, so I won't go into details of how these questionnaires are. This was a very important Indian quality of life questionnaire. I have a blog on questionnaire development which you can look at. So there are many questionnaires for cataract specific, glaucoma specific, AMD specific. So once you have the quality of life, what we do is do ISER. That is, ISER is cost per quali, that is incremental cost effectiveness ratio. So this is generally what most governments are calculating. So we can't go into details of how this is done. In the US, any new intervention is going to be allowed if the cost of that intervention to the healthcare system is 50,000 USD per quali, right? In the UK there are similar numbers. So when governments look at if they want to adapt, so what if they want to bring in femto cataract surgery and offer it to patients free of cost? Will they do it? This is sort of the number that they look at. So differences between various outcomes are actually done using these parameters. So what is cost benefit? What will come straight to how it is measured. Cost is of course in monetary terms, and benefit is also purely in monetary terms. Cost effectiveness, where cost of course is monetary and effectiveness is measured in non-monetary units. And there are many ways to do it. Cost utility analysis is what they do using quali, right? So cost utility analysis is generally the best one to do. For want of time, I'll quickly show you some examples. This is health economics and safety considerations for AI applications in diabetic retinopathy screening. They're particularly looking at how AI can bring down costs for screening. Like Dr. Manisha was mentioning, there have been a lot of studies which have looked at many different technologies, and they have clearly shown that the cost of diabetic retinopathy screening will dramatically reduce if you start employing AI. This is an example of that femtosecond such study. This is a large study done in France. And what they found is this is the ICER value, ICER, right? So ICER showed that more than 10,000 euros it will be saved per additional patient whose treatment when treatment success is with phacoemulsification compared with flax. So flax will cost 10,000 euros more. So a lot of complicated analysis goes into these things, but then that's a very high cost for the government to spend additionally. So so the flax has now not been included in any of these major Western countries, and manual phaco is still being sponsored by the state. So how do you choose the appropriate analysis? Basically, so cost utility is the best one to go, like I said. So in summary, value-based medicine really is the need of the hour, and cost utility analysis really should be the cornerstone for what we are doing. Unfortunately, it requires a lot of processes where we need to develop questionnaires with robust methodologies. Then we need to generate data using these questionnaires. Then we need to calculate the quali, and then we need to calculate the ICER, right? So this is a very sort of relatively lengthy process. In India, we don't have questionnaires at all, even for simple diseases like glaucoma and cataract. So it's a relatively long process. Still, for now we can use surrogate measures to assess health economics, which are relatively simpler, such as indirect costs and others that I've showed you. But so this is generally the way forward. We need to first understand what is required, and then go ahead and develop these ICERs for India specific, and then allocate funds for those. So this was a little bit about health economics. I'll take a couple of minutes more, if that's okay.
Yeah, I think the next session people are
waiting. So I'll just show you, only two slides on insurance and anti-VEGF. And this is something that cannot be denied by insurance agencies. I'll just quickly show you. So this is sort of the crux of the whole thing, where the government of India came up with new standardization guidelines. The IRDAI came up with these guidelines from October 2020, where they said that anti-VEGFs cannot be denied insurance. So this is a QR code. If you have the time, you can scan it. So what they've said is intravitreals cannot be denied. The coverage that is allowed is 50% of the sum insured. No minimum was given, but intravitreal injections and especially biologics cannot be now denied. Cannot be denied insurance coverage, right? So we are, a lot of meetings have been done, but overall crux of the story is that that intravitreal injections now cannot be denied. I I think that was pretty much it. Thank you.
Thank you so much, Sunny, and that was wonderful. And obviously, we don't have time for any Q&A, but I sincerely apologize for the next session, moderators and audience. Thank you so much, Dr. Ravindran. Can we have a photograph, if you permit,